How many in the audience do more than 50% of their angioplasties via the radial approach? Okay, so I'm talking to a radial crowd, so I may be preaching to the choir, as we say. Well, I hope at the end of this, and as I can see, most of you have already voted with your practice, that I can tell you that once a guide catheter is in place, they're the difference between a femoral and a radial approach end. And we'll discuss some of the newer techniques with transradial approach that allow us to get there. It turns out that when we looked at our practice, that almost 70% of our cases were single vessel, single lesion cases. And for those of you that are used to using 5 French systems, it turns out you can do most of these with a 5 French system. It's when we get into, obviously, talking about bifurcation disease and other more complex, where we bring more hardware in and we like more access, that larger guides come into play. But it turns out it doesn't matter whether or not you use an EBU from the leg or from the right wrist, that the backup that you get is probably going to be comparable, although there could be some points of quibbling there. The other thing is that I think the technology has evolved because the use of guideliners or mother-daughter catheter techniques has really changed our ability to provide support and to tackle some of these harder lesions. And finally, I think once you understand that you don't necessarily have to have the capacity to perform simultaneous kissing, whether it's balloons or stents at the same time, but sequential approaches really allows you to be a little bit more thoughtful in terms of how you approach these diseases. So by way of background, I think it's important before we tackle the bifurcation side of this that we talk a little bit about some of the techniques and strategies as well as the technology that allows us to perform these from the radial artery. Here we have a case shown on the left. It's hard to see, but this patient had unstable angina and has a previously placed stent. And at the distal end of this, there was an exit angle which made it almost impossible to get a balloon down. We were using a 6 French system here. You can see we have a very aggressive guide position. We had a second wire in at one point, and it wasn't until we brought the guide liner down, shown on the upper left, and literally almost crossed the lesion with the guide liner itself, where we were able to get the equipment in place. And once we did, though, it was a very simple procedure to complete. We can see also that we have here, I think a lot of people fear that trying to do a rotablator from the wrist would be complicated, that the sizing of the guides that are available from the wrist, typically 6 French or smaller, would be difficult. But you know, when we look at today's use of rotablator, this is really for preparation. It's not for treatment as we used to do in the old days. So having 8, 9, and 10 French guides, which we used to when we did rotablator, is no longer necessary. And a lot of the prep work can actually be done with a 6 French system. If you have done a sheathless guide approach, you understand that you can have a traditional 7 French femoral guide without too much difficulty. We have to make a small dermotomy. We have to have a mother-daughter approach to get the guide catheter up through the radial artery and navigate the brachial artery. But all of this can be done for individuals that are experienced in using the radial approach. And ultimately, with a 7 French guide catheter in, I think you would find out that you're really not any different from the radial approach than you are from the femoral approach. So here we had a patient who had extensive in-stent restenosis. In fact, this case came to me because an attempt was made to do a simple balloon angioplasty of this case in an outside hospital, and they ruptured every balloon they tried, so they sent them to us. And in many ways, and that was an attempt at a femoral case. So not that I was trying to grandstand, but I did want to show that we could do this from the radial approach. And here we prepared this with a rotablator, and actually it turned out to be quite an easy case to perform with the 7 French sheathless guide approach. Well, what about any clinical data that we have besides just experience and showing all my cases? Well, if you look at the transradial versus the transfemoral intervention for left main coronary bifurcation, so perhaps you could argue one of the most important subsets of all the bifurcation lesions, we can see here in this Korean study that in fact the transradial approach was associated with a, excuse me, let me go back, was associated with a decrease in both TVR as well as MACE rates, which was a somewhat surprising finding given that this was a randomized clinical trial. Now, whether or not, in fact, that the radial approach somehow has a decrease in MACE rates is probably going to be problematic because, as I already told you, I think once you have your guide catheter in place, it's really irrelevant whether or not you got there from the radial artery or from the femoral artery. So here's a case of a bifurcation shown on the upper left, LAD and diagonal. This is a 6 French EBU, and it turns out, at least in our experience at Wake Forest, that the EBU guide from the right radial actually has a tremendous amount of support. It's relatively easy to get in, although there are some learning experiences that one needs to go through to understand how to manipulate it to get there. But once it's sitting in the ostium of the left main, it's a very stable platform. Here we're performing, getting ready to do a sequential technique. And again, as I mentioned in my first presentation, the DK terminology really doesn't do justice to the fact that this is a sequential kissing technique. And as we think about trying to treat bifurcation disease, it's the initial optimization of either the stent or the entry into the side branch that allows us to perform ultimately, I think, a durable and very successful procedure. And you can see on the upper right here that we have a very credible result, even though there's probably fairly diffuse disease in the middle of that diagonal branch. So I want to show a case here. This is a 74-year-old male, again, admitted for unstable angina. We have Medina 110 LAD diagonal disease, as well as some ostial circumflex disease with mild wall irregularities in the right coronary artery. 5 years ago, we flipped our lab from being a preferred femoral lab to a preferred radial lab. All the operators in the lab made this transition, and we've had a few publications describing our experience and the learning curves associated with this. And I can tell you from personal experience, there is a learning curve that does exist, most of which, though, is navigating the pathway from the wrist to the heart, not necessarily in the intervention itself, although one has to be cognizant of the technology that's available with guideliners in particular. So this is actually a case one of my partners, Dr. David Zhao, performed. And you can see here that there's a subtotal diagonal after a proximal LAD lesion. This was performed from the right radial artery, which is our preferred access for most of these cases. Here we have wires in both the LAD and diagonal. You know, oftentimes when there's a subtotal occlusion of one of the side branches, it's very hard to understand whether or not, in fact, that you would need to revascularize that vessel at all. But as you can see, this is sort of growing in size. So this was a planned approach looking at after the first kissing balloon, because of the size of the side branch, was an attempt at what Dr. Zhao calls a mini culotte, as opposed to the traditional culotte where there may be overlap in the parent vessel of approximately a centimeter of stents in the branch, and the main channel, this is just enough scaffolding in the main branch, actually, much like the analogy with the Triton stent, to have purchase when you dilate it. So here there's pre-dilatation of the diagonal vessel. Actually, excuse me, there's a stent there. And then in the case of this side branch, there is additional disease. So as a preferred strategy, if you're going to do a two-stent strategy, always stent in the side branch to the full extent that you can. In the event, for some reason, you can't get back in there, and it'd be a little under-treating the patient to leave them with extensive disease in the side branch at the end of the procedure. In this case, with the Kulak technique, the wire that was in the diagonal vessel is then pulled back so that you know it's still within the parent vessel, and then advanced down into the distal so we can see the two wires there in the LAD coronary artery. Here now a balloon is passed through the struts of the stent in the diagonal within the LAD itself. So essentially the analogy of performing a balloon inflation of the side branch, in which case this is the parent. Here we can see that a Zion stent is placed in the main channel through the struts of the stent in the diagonal vessel. Here's a final kissing balloon inflation of the LAD and diagonal vessels, and I think, again, I just can't emphasize enough what Dr. Mahmood says, and that is that optimizing results really depend on making sure that you have optimal expansion in the side branch and that you have appropriate apposition against the wall in the main vessel, which requires a kissing balloon. The final result is shown here, and again, you can see the size of this side branch now as opposed to what we saw on the first. So I showed this at TCT in 2012 when I was asked to talk about the benefit of doing transradial PCI, and I started my career as a femoralist like many of us did before the radial approach really, at least in the United States, approached the maturity that it has today. But I think in today's world, I really think it's the right approach for the right lesion, the right patient at the right time. So whether or not you're going to approach something from the femoral or the radial, there will be circumstances where each of them might have a little bit of a benefit or added approach. And at the end of the day, when you're in the cath lab with a patient, the question is going to be, what is the best way to treat that particular patient? And having skills in both ways allows us to be a comprehensivist, which I think is the optimal approach to take care of our patients. Thank you very much.